Hi, everyone. Good evening and welcome to our 2025 Accessibility STEM Talks. This is our final STEM Talks for the month of June and for the 2024-2025 academic year. So we're very excited to get started and are happy that you could be with us this evening. For today's event, just some quick housekeeping. You're going to hear from three UHN speakers very shortly, Madalena, Hanan, and Inez. They're going to talk about what they do with respect to the subject of accessibility. And after they've all presented, we're going to have a Q&A period. This event is being recorded, so make sure you leave your microphones and cameras muted, please. And if you have a question, feel free to submit it using the Q&A box at the Zoom toolbar. So you'll see a Q&A icon and you can click on that to submit your question. Lastly, if you are here for our Certificate of Participation program, just make sure that you use the link to join that you got when you signed up for the program, and that way we will have your attendance from the Zoom report to mark towards the certificate. But with that said, I'm going to let Madalena take it away and get started with her presentation.
Good evening, everybody. My name is Madalena Lugas, and I'm a second-year PhD student at the Rehabilitation Science Institute at the Temerity Faculty of Medicine at the University of Toronto. And in addition to being a student at the University of Toronto, I'm also a trainee at the Kite Research Institute at Toronto Rehab Hospital, which is a part of the University Health Network. Okay, so a little bit about my background. I am from Bradford, Ontario, Canada. It's about an hour and a half north of Toronto. I've been working on a team called Team Encore for the past 4 years. However, I've been at the University of Toronto for a very long time. This is my 8th year I'm finishing there. Previously, I attended undergraduate as well as a master's, and then now I'm in my PhD at the University of Toronto. So 4 years of my undergraduate degree, I was there, 2 years of my master's degree, and now into my PhD. I enjoy all types of traveling and physical exercise, especially events such as cross-country running and cycling. So in terms of traveling, one of my best or favorite things about this job being a researcher is I've had the opportunity to go all over the world. I've been to places such as Vanuatu, and I've also am planning on going to Spain this summer for work related to my research. So like I said before, I've been at U of T for a long time. So after high school, I completed an honors Bachelor of Science in the Arts and Science program at University of Toronto, where I majored in human biology and environmental biology. And then after I finished my undergrad, I went straight into my master's degree at the University of Toronto, where I was also a trainee at the Kite Research Institute, part of the UHN. And then after my master's, I went straight into my PhD, where I continued my work at UHN. So a little bit about my work. So the title of my work and its relation to accessibility is Rehabilitation Health Services. So essentially what I do is I look at how social factors, financing systems, organizational structures and processes, health technologies, and personal behaviors affect an individual's access to healthcare, the quality and cost of rehabilitation healthcare, and ultimately individual well-being. So what I do is I look at how personal factors may shape an individual's access to healthcare, and that can be related to things such as education level, income, geographic location. Then I look at whether or not they're able to access healthcare, and then I look at the quality of the healthcare they receive. So, for example, we know that the quality of healthcare is, for example, different in a rural versus urban area. My specialty in particular is I look at how relationships affect quality of life for people living with dementia. So my actual thesis work for my PhD is entitled The Association Between Social Connection and Quality of Life for People with Dementia. So social connection is a term that describes how people connect, relate, and interact with one another. It describes our connections and our ability to be connected to others. So essentially, social connections and the way we interact has 3 different components. The first being structure. So structural connection describes whether or not we actually have contact with people and the frequency of the contact we have with people. It's often the quantifiable part of how we interact. The second component of social connection is function. So this describes the receipt or exchange of support that an individual has. And this can be related to things such as financial support or emotional support. And then finally, connections we experience in terms of quality. So that can be whether our connections are positive or negative. So for example, just because we're connecting with others doesn't mean that those relationships aren't strained, which then has a negative impact on ourselves and our health. So I'd like to remind everybody that social connection is a basic human need, and regardless of age or where we reside or personal characteristics, everybody deserves to have connections that make them feel human. Connection is a huge part of us humanizing ourselves. And so essentially what my work does is I'm using Canada's first national data set for people living with dementia called the Compass ND study. And I look at how relationship factors impact the quality of the relationship people have. And I look at how that impacts their quality of life. So a little bit of a week in the life as a researcher here at UHN. Opposite to what most people may think, no 2 days are the same. I spend a lot of my time advocating and about only 50% of my time on thesis work, which is opposite to what I'm sure a lot of people assume. So I am not a lab bench researcher. I don't work in a lab. Most of my time I work from home or I work from different sites across UHN. I attend things such as weekly lab meetings. I participate in data collection. So part of this involves me going to long-term care homes to collect people's data. I spend a lot of time analyzing data using software such as R or Python. And like I said, half of my time is spent advocating. So that often involves me presenting and networking with people in order to build relationships and bring and learn from other researchers who are doing similar work or different work so that we can ultimately all work together to improve quality of life for people across Canada. I've been really fortunate to have a very diversified research career. So I've attended things such as the MasterCard Center for Inclusive Growth. So that's the photo on the bottom left. I've also participated in Rally for Rehab and what is now We Walk United to raise money for the University Health Network. And I've also had the opportunity of traveling to countries such as Vanuatu, where I worked with the Red Cross to advance research for Indigenous communities there. So the importance of my research and why I chose this career. So my research focuses on improving quality of life for people with dementia. And I'm really using my work to advocate for policy change. So looking at how we can implement programs and policies that protect and support people living with dementia so that they can experience a good quality of life. And all of my inspiration for this work is rooted back to my dad. So when I was 8 years old, my dad was diagnosed with multiple sclerosis. And growing up as a young child with a dad who was living with a disability, I really became passionate about advocating for a world where people living with disabilities are included and accepted and, destigmatized. So just want to thank you all for listening.
Thank you so much, Madalena, and that was special ending to end on. Next up, you're gonna from Hanan, also from the Kite Institute.
Hi everyone, my name is Hanan, and I'm a research analyst at the Enable research team. Enable stands for Environments, Aging's Biomechanics Lab, and our research team is also part of the Kite Research Institute. And it's the research arm of the Toronto Rehabilitation Institute, which is all a part of UHN. So my background, I was born and raised in Toronto in the East End and have lived here my whole life. I've been working at the Enable research team from 2022, and outside of work, I enjoy reading, listening to music and podcasts, and knitting. I've included one of my recent knitting projects. It's a multicolored cardigan, and then some screenshots of my current favorite podcasts, usually true crime or daily news and a music-related one. For education, for university, I went to the University of Waterloo and studied biomedical engineering, getting a bachelor's of applied science. In this program, I really learned I enjoyed designing products using a human-centered design approach. So a really common joke about engineers is that they build really cool things, but nobody needs them. So using a human-centered design, you get to learn exactly what people need and build products that will actually meet their needs and be useful. So during my last year of university, I joined the Enable research team. And here we focus on research related to accessibility within the home and the built environment. So the built environment basically means all man-made spaces. So this can be roads, sidewalks, malls. It's really wide encompassing. And we basically study how to design these spaces to be made accessible for all people, um, both with and without disabilities. So where our research leads to is guiding clinicians on how to make the best recommendations to their clients and trying to implement research-based practices into like the building code and safety standards. So this is a really broad area of research, but to give an example of things we study, previously we spent a long time studying stairs and handrails and how to make them safer to prevent falls. And the best way to design stairs and handrails, so if a fall did happen, how can people which design best help them recover from those falls. And currently within the home, we are focusing on how to make bathrooms safer. And within the built environment, we're studying the dimensions of public spaces and how they can be made more accessible for people who use mobility devices. So lots going on here, but my specific project is working to understand how we can design safer bathtubs. So everyone bathes or should, and falls are the number one reason among older adults and a really common reason among adolescents for visits to the emergency department. So, and within the home, bathrooms are the number one location for falls for older adults. And one of the contributing factors to this is the how dangerous the bathroom environment is itself. So when entering the bathtub, you're stepping over an obstacle, which is the bathtub rim. It's a really slippery environment. And if you wear glasses or contacts, you'd probably be entering the environment without them on. So your risk kind of increases because of your low vision. So knowing this background information, our research objective is to understand the effect of bathtub rim design on things like rim clearance, so how far your foot is above the rim, and this is indicative of like you hitting the rim and falling. Your friction use, so if you're going to slip when entering the tub, and how rim design affects your obstacle crossing technique. So we care about this because some techniques are seen as more risky than others. So if you step really close to the curved edge of the bathtub, you could be at more risk of a fall. So these are the kind of the things we're studying, and our goal in completing this research is basically to standardize bathtub design and recommend a standard that is the safest for use. So my week in the life, I do say that there are kind of two distinct days for me. There's lab days and desk days. So what you do on those days can differ. For lab days, we're often setting up the lab space for our experiments. So before you start a new project, we have to build or install our rig. So the picture here is one of our recent bathtub setups. So we would be building that and setting that up in the lab with the engineers who help us build everything. And then after everything's built, you usually do pilot testing. So that is basically doing a dry run of your entire experiment with people internally to see if there are any changes that need to be made and iron out any details before you bring in real participants. So after that's all figured out, you would then do your actual data collection, where you recruit participants from the community and they complete your experimental design. So after that, after your lab days are done, you're usually at your desk processing all the data you just collected and analyzing that data, and also writing a lot of reports. So those are the two kind of distinct days, I would say, that happen for me. And why is my research important? I think it's important because it helps make the home and built environment safer and more accessible for everyone. I chose this work because it's human-centered design, which is what I learned I liked in my undergraduate program. And we are able to actually make an impact on everyone. When you make things accessible for a certain population, it tends to make things accessible for more people in general. So by making bathrooms safer for older adults, it should, in theory, be making it accessible for young adults, children, and everyone in between as well. So our research is able to make a real change through implementation of our research-based recommendations into the building codes and standards, and the use of research by clinicians to make recommendations to their clients. We have actually been able to make changes to the building code, to the national building code for those stair and handrail designs. So we're really proud of that, and we hope to continue making those changes with our current research. Thank you.
Thank you, Hanan. That was wonderful. And very cool. Like if anyone wants to Google, you can Google Stair Lab at the Kite Institute and find like those building codes Hanan is talking about. Next up, Inez, whenever you're ready.
Everybody. So my name is Inez. I'm a speech language pathologist at Toronto Rehabilitation Institute, which is part of University Health Network. The title is very often shortened to SLP. So if you do hear me using that acronym, this is what I'm talking about, speech language pathology. It can be a bit of a misleading name or title, I should say, because we also do help folks with swallowing disorders, but I will get into that in just a bit. So I actually work in several programs across multiple sites of the Toronto Rehab branch of UHN, which is a bit of a unique role, or I hold a very unique position because it's not very typical for any clinicians to be at more than one site. There are a few clinicians who are working at two sites, maybe splitting half and half, or 50% of their time at each. But it's only me and one other clinician that I know of who actually go between all three of the sites. And so those programs include the dementia unit at University Center, MSK and geriatric units, stroke rehab, neuro rehab, and spinal cord rehab, which are all spread out across the different Toronto rehab sites. So I'm originally from Windsor, Ontario, although I haven't lived there in quite a long time. I moved to Toronto in 2020 for my master's degree, and I've been working at Toronto Rehab for 2 years. My work anniversary was just a few weeks ago, actually. And some of my favorite things are going for long walks around the city, learning new languages, supporting local artists at showcases or events, and creative writing. I don't have very many pictures of myself doing these things, but I put a screenshot of my Duolingo streak for Portuguese, and this is a Be Real from back when back when people were using Be Real a lot, and I was in a run club. I have to say, actually, having a few of these hobbies really do help with my work, especially with the language learning, because I do have quite a bit of patients who don't speak English. And so the language I've been learning most recently on Duolingo is Portuguese, and that really helps. We have a big Portuguese speaking population, or I should say, a lot of our older patients are exclusively Portuguese speaking. So I did my undergrad at U Ottawa. I don't have a picture of myself graduating because technically I never had a graduation ceremony. I did finish the program in 2020, but our graduation ceremony was postponed for a couple of years, and I unfortunately was not able to make it. And then I did my master's degree, or I did a Master of Health Science in speech language pathology at the University of Toronto. And that was also, I mean, it started in 2020 and ended in 2022. So those were still peak pandemic years. And it was the majority was of the program was online. So I put a screenshot of what my classes looked like. So my work is clinical practice across a wide range of patient populations. As I had mentioned, I work in a lot of different programs spread across three different Toronto rehab sites. And so my work primarily consists of assessment and treatment of swallowing and communication disorders. A lot of people don't know about the swallowing aspect of it. And so assessment for swallowing disorders can look like a bedside swallowing assessment where I'm essentially just checking to make sure that folks can swallow safely without showing any signs of choking or inhaling their food or their beverages. Sometimes we need to take some people to video fluoroscopy, which happens in an X-ray suite. And for the clinicians at Toronto Rehab, this actually happens at Toronto General Hospital. And then communication assessments are, I mean, they can happen in patient rooms, and there are formal and informal ways of completing these assessments. And then treatment looks like making diet modifications for folks who are having trouble swallowing very chewy foods or thin liquids. So we can make their foods softer, smoother, more bite-sized. We make their liquids thicker for safer swallowing, and it's often not permanent. We can also teach compensatory swallowing strategies if we don't think that diet modification is necessary, but patients would benefit from following a few guidelines or specific strategies to make sure that their airways are protected while they swallow. And then for communication, treatment looks like teaching clear speech strategies, therapy for word finding when folks uh, start to not start to, but as a result of an injury, they may have sudden difficulty remembering words. This can range from quite mild to very severe. We also support functional reading. To read a contract that related to any aspect of life, like for example, a lease or a work contract. We also recommend memory strategies for folks who are having trouble with their memory after an injury. We practice social communication, build better voice habits for folks with voice issues, and then we also can provide alternative and augmentative means of communication for folks who don't use words to speak, or I should say not words, but don't use speech to speak and or speech to communicate, and much, much more. So it's a very niche field, but it can actually be very broad. And because of the nature of my role, I do actually I get to see it all and do it all. Like I had mentioned before, I work with multiple patient populations, which is also a bit unique. Typically, clinicians are working or are specialized in one population. So I have colleagues who have worked like on the stroke unit for the last 10, 15, 20 years, and they're very, very familiar with that population and their specific needs. Same goes for traumatic brain injury patients. And I have a colleague who also worked in spinal cord injury for 22 years, I think. And so she's the expert that all of the clinicians at Toronto Rehab look up to and go to when we have questions about spinal cord injury. I also have worked with patients who have recently had an organ transplant, usually lung transplant. I work with patients with dementia, and I work with patients with head and neck, or who've had or currently have head and neck cancer, although that's much less common. And I've just included the different like the primary issues that we see with patients in each population. So for stroke, we see a lot of folks with swallowing issues, folks who are struggling with clear speech, and who have developed a language disorder as a result of the impact to their brain. And we do refer to this as aphasia, and it is very commonly known to anybody who is more or less familiar with aphasia as a disorder that impacts your ability to remember words. In the TBI population, a lot of cognitive and social communication, so memory, attention, turn taking, tangentiality, topic maintenance. In the spinal cord injury population, a lot of swallowing as well, but also voice issues. And we have to help out with folks who are getting used to life with assistive technology. If they, for example, can't move their they can't move their arms, or they don't have very good fine motor control in their hands, they may need to start to rely on voice recognition software to be able to control their devices, and so on and so on. So, so my uh, goals as a clinician, other than, of course, always improving my practice, always finding like the best and latest evidence-based methods for providing assessment and treatment. I do have quality initiative goals for Toronto Rehab, which include widespread education and consistent adherence to safer swallowing strategies among allied health, because this is an issue that I do run into quite often where um, uh, nurses the speech pathologists rely very heavily on nurses to help implement our recommendations and monitor for adherence to our recommendations. But if they're not fully aware of what the typical recommendations are, it can be very difficult for them to um, accurately monitor and let us know if, if one of the patients that we are following is continuing to have swallowing difficulties because our recommendations are not working and we need to pivot or come up with a new or implement new strategies, or is it because they're not actually following the strategies properly? And one of the main ones is actually, it's very simple. It's just sitting up straight to eat. I'm also very interested in standardizing functional goals, specifically among speech pathologists in rehab, while still centering the patient. And then in terms of accessibility, I'm very interested in implementing low-cost hands-free drinking systems for in like as a standard care practice. This is particularly for the spinal cord injury rehab center that I work in, where a lot of our patients, like I had mentioned before, can't move their arms, or they don't have very good fine motor control in their hands. And so unfortunately, they're very dependent on the care team for hydration throughout the day. And often, they could be thirsty and waiting maybe 30 minutes before their nurse can come back and give them a sip of water. And hydration is so important for, I think actually I have a slide that's coming later that explains why it's so important. But I mean, it's a basic human right. And so I am interested in finding more cost-effective ways of providing hands-free drinking systems to our patients at Lyndhurst, which is a spinal cord injury rehab site. Quality educational resources for patients and their families, widespread education of communication strategies among allied health, for the same reasons as the widespread education of swallowing strategies. We have a lot of folks who they've lost the ability to communicate the way they were used to doing so before, let's say, a stroke. And as speech pathologists, a part of our job is to find ways that of communicating with them that work for them, as we also try to get them back to or close to their pre-injury baseline. But while that's happening, again, communication is a basic human right, and allied health should be well versed in communication strategies for folks who are uh, having difficulty after a brain injury, or mostly it would be brain injury that would result in a language disorder. Um, and then a more recent quality initiative that I've started brainstorming is patient menus in multiple formats in or media. This is, I mean, I could get into this, it's a whole thing, but basically, like very recently, patients have gained access to an app to be able to order their meals, but not every patient has access to a device where they can download the app and use the app, and or even if they do, they don't necessarily know how to work the app or navigate the app, because I mean, a lot of our patients are quite a bit older. Okay, so I think I'm probably running out of time, so I'm gonna make this quick. But the reason why it's important, at least for me, and it is objectively important to um, at least be mindful of these goals, it's mainly for airway protection during swallowing in the interest of reducing risk of developing aspiration pneumonia, which is a quite serious chest infection with a very high mortality rate. And so it is in everybody's best interest to make sure that we're doing everything we can to reduce the risk of aspirating, which is inhaling food or beverage, so that we can reduce the risk of developing these infections, which can, I mean, not only is that a life-threatening condition, but it also, um, with respect to progress in rehab, post-injury, and like post and after being in acute care, it delays, well, it limits the patient's ability to participate in rehab. It might delay their discharge date. It might delay, them being able to get back home, which a lot of them are very anxious to do. Um, for standardization of functional goals in rehab while still centering the patient. It's really important to prepare the patient for return to the community. But it's also equally important to make sure that what we're preparing them for is something that's actually meaningful to them and something that they participated in before their injury. Like I had mentioned before, for low-cost hands-free drinking systems, adequate hydration is crucial for recovery in hospital. The risks of dehydration include prolonged wound healing, increased physical and cognitive fatigue, and increased risk of associated complications, which all limit the patient's ability to participate in rehab. Quality educational resources for patients and their families is important because rehab continues beyond the inpatient setting. And actually, one of my main goals as a speech pathologist is to teach families how to be the patient's therapists after they leave, because I can only be involved in their care for so long. But of course, recovery is not something that happens overnight, and it's certainly not something that happens in the few weeks that they're with us, as much as I would love for them to be fully recovered, although a lot of our patients do make a lot of progress, and it's really wonderful to see. And I think, yeah, I think I've covered the other the remaining goals, so I'm just going to continue in the interest of time. So a day in the life, or sorry, a week in the life, for me does look quite different from a lot of my colleagues' typical week, and it also different every single day. No 2 days have ever been the same, especially because I bounce around between three different sites, and as time goes on, those hospitals, they implement changes for the better, and I have to sort of be keeping up. And then there are always new patients to see, new cases, new things to learn, especially because I'm still relatively new, and I'm also learning to assess and treat many different patient populations. There's so much more. My learning is spread out across a lot more, or a wider breadth of um, I guess, specializations or at least patient populations. So a day in the life involves safety huddle in the morning, which I put twice, oops, completing assessments, treatment sessions, collaborating with allied health, and completing documentation, which is, I'm just joking here. It's actually not our favorite part of the day at all, but it is an important part of the day. On a weekly basis, there are interprofessional rounds where the whole care team comes together. So this includes speech pathologists, occupational therapists, physiotherapists, the doctors, the nurses, maybe sometimes the dietitians, and unit managers or service coordinators. And we discuss each patient and talk about how much progress they've made, what goals are still outstanding. We talk about where we are in the discharge planning process. And it's a great opportunity for all of us to sort of pool our observations and provide insights that, we've each we've collected from our sessions in the past week with each of the patients. And then on a monthly basis, there are continuing education sessions, participation in quality improvement. So these include team meetings, quality improvement initiatives, and committees. And like I said, as especially in the life of a float, which is just a clinician who goes from bounces between different hospitals, and mostly covering colleagues who are either sick or on vacation, or sometimes actually currently I'm covering a position at Lyndhurst Center, which is a spinal cord injury rehab site. I'm covering my previous colleague's position as she actually accepted a position, a managerial position at Toronto General Hospital. So this was a colleague who was at that hospital for 22 years, and now I've had to step in while they find her permanent replacement. Of course, I could apply myself, but I actually really do love my full-time floating because of everything I get to learn and all the people I get to meet. But it is a very unpredictable life and job. And the important.
Sorry to cut you off. We're a little short on time. So do you
Okay, no worries. I think this was the
want
last
to cover?
slide, and it's,
Okay.
yeah, I think I've pretty much covered it.
Okay, so maybe we'll get started, but do you want to take 30 seconds to kind of cover your last slide while I pin everyone?
Yeah, sure. So, the importance of speech pathologists in rehab is giving people a chance at getting back to the things that they love and need to do, even if that may look a little bit different for them post-injury. And this is including swallowing and communication. Like I had mentioned before, we complete our assessments, and then we provide recommendations, and then and teach strategies, and then we practice implementing those strategies in daily life so that folks still have access to safe swallowing and communication when they leave the hospital. And the reason I chose this career and the reason I love it so much is because I have always loved communication. I've always been passionate about it. I'm a big talker, as you can see. I also really love working with teams. I'm passionate about patient care and accessibility. And I'm really excited to get going on those quality improvement initiatives. And I love the opportunity to be dynamic and creative. This is a master of health science, but I also think of it as an art a lot of the time because of how much kind of creative freedom we have in designing treatment plans. So, and thank you so much for giving me the opportunity to share.
Thank you for sharing with us. So yeah, if you have questions about what Anne has just covered, you can put them in the chat. Sorry, I'm losing my voice. And we're gonna get started with our Q&A. So I saw a couple questions come in, so I'm gonna try and kind of speed through them and direct them appropriately. But I see first up, we have someone asked Madalena specifically, what exactly are lab meetings and how is it different from actually working in the lab?
So, great question. My lab meetings are a little bit different because nobody in my team works in a lab setting. We don't have lab benches. Um, all of our work is either in a long-term care home with patients or in a hospital setting with actual patients, whereby we talk to patients to collect our data. So basically what we do is we all come together and we discuss the projects that we're working on, the type of data collecting, what we're thinking about doing. And essentially, we all give each other feedback. And then if somebody, for example, yeah, so for example, at my lab meeting tomorrow, I'm presenting my work and my progress on it. And then everybody else in the lab is going to give me some feedback on that. Even things such as communicating with different individuals that we work with, such as clinicians, that can include psychiatrists, nurses, social workers. We give each other tips and tricks on communicating with multiple levels of individuals who work in clinical settings.
I think that was a good preview, but like you said, it'll probably be different depending on what lab someone is in too.
Yeah, it's very different. But I can only speak in terms of somebody who doesn't do lab bench work. I only work with real people.
I see one for Hanan here. Does your research on how to make buildings more accessible include the actual blueprint of the building slash the construction portion in building a home?
So I would say that if our if our recommendations get implemented into the building code, then yes, it would have to be adhered to. And so, for example, like that stair research we did that got implemented into the national building codes, when it's at that level, then yes, at the blueprint, the architect would have to follow our regulations when making those staircases. But a lot of our research, unfortunately, like things aren't designed to be accessible. So we're working with things after the fact and seeing how can we change them now. So with the research we're doing on making to see if the built environment is accessible for people who use mobility devices, we're seeing if in the next iteration of the building code, like, do we have to make spaces bigger? So we're doing a lot of research about that. So I would say yes. Generally, our research would get implemented at that blueprint level.
Thank you. And then I think I saw a question for Inez. What are the pros and cons of working in SLP? You kind of answered, but maybe do you want to briefly answer again?
Yeah, sure. So the pros are, I mean, it would depend on what your personal interests are and what's important to you, in your work. For me, the pros are getting to work with people, being patient facing, getting to be involved in, something so important as their rehab after. I mean, for a lot of them, this is kind of like the worst thing that's ever happened to them or the most difficult thing that's ever happened to them. And it's a responsibility I take so seriously. And to know that, they have that this patient has at least me in their corner, and also like getting to know my colleagues and knowing how competent they are and how caring and compassionate they are, like knowing that they have such a great team behind them that really like it makes me feel good. Um, on the flip side of that, it is really difficult to see these folks going through the most difficult time in their life. And like I had said before, I mean, most of them are not fully recovered by the time they leave inpatient rehab. And so you do always worry for them, and it's always a little bit sad to see them go, especially if you've been following them for a while. I don't typically actually follow folks for that long because I'm bouncing around so much, but I have had the opportunity to follow them for some months, and it's always tough. It's always tough to see them sort of go off, back to real life, and you wonder if they're going to be, if they're going to be okay. But of course, that also has a little bit to do with like the work that we put into it. And so it's such an honor and a privilege for me to like do my best for them. Um, but it is a massive responsibility, and it is, I would say, for anybody considering going into healthcare, you really need to be like 110% committed, because what you put into it is what the patient's going to get out of it. And it is a massive responsibility.
I think that was a nice piece of advice. And then I saw someone asking in the chat about advice for volunteering in long-term care homes. I don't know, you're in the hospital, Inez, but Madalena, you work with older adults. Do you want to answer that one?
Sure. During my master's degree, I did my project on working with people living with dementia and long-term care homes. And I think the biggest thing is they are going to be so excited to talk to you and interact with you. And your presence being there is just going to be the light in their day. So I think just being authentic, being yourself, not being afraid of them. I think some people are a little bit nervous about approaching long-term care homes because people are in quite a vulnerable state. There's a lot of people, you know, but regardless of their health status, having that time to be one-on-one with them is so important. Like, don't be afraid to hold their hand. So I find in my work, when I went and have collected data, some people will just reach out and want to hold your hand. They may not have any kind of verbal communication, but just taking that time to, humanize them, make them feel seen and heard is so important. So being compassionate, and just listening and sharing and having a two-way open street, I think is super important.
Thank you. And then I think someone is asking Hanan about how long does it generally take people to adapt to assistive technology after an injury? Is this something you would know?
This isn't really something I would know. I don't think I don't work directly with patients, so I wouldn't know the answer to this.
So maybe we can throw it to Inez, who does work with patients. Yeah.
Yeah, yeah. So actually, it's very interesting to have heard Hanan and Madalena speak, because I am on the ground, so to speak, with these patient populations. I get to see it all in action, and what I've seen is that with daily therapy sessions with physiotherapists and occupational therapists, like typically patients do pick up assistive technology pretty quickly, and actually it is like a discharge milestone that the patients be able to use the assistive technology before they go home. Because otherwise, there's really not, we're not, we can't confidently discharge them from the hospital. The whole point is to get them ready to go home and, adjust to a bit of a new normal, whether that be temporary or permanent. So yeah, within a few weeks, they get used to they adapt to their assistive technology in most cases. Of course, sometimes there are sort of like factors that we can't predict, or sometimes um, the impact of the brain injury is such that like their cognitive impairments are limiting in terms of adapting to new tech. But I would say for the most part, even with those with cognitive impairments, like their family, that's when the family becomes key, and teaching them how to use the assistive tech, it can be very helpful and very effective.
And would you say that you've seen the tech has changed fast in the time that you've been working, or is it something that's, every 5 to 10 years or longer?
So, or you're asking me?
Yeah.
I have not been working long enough to really give a comprehensive or maybe even an accurate answer. No, I'm so sorry. I see the tech from afar and I think, oh, that's cool and good for them. But I'm only familiar with voice recognition tech when it comes to assistive technology.
Thank you. And then I see a couple questions for Madalena about U of T. A couple people are going there. Someone is even going to the same program you did. Do you have any advice or anything you want to share?
Yeah, absolutely. I guess the biggest piece of it, number one, U of T is a fantastic university to start your education, regardless of level of it being undergraduate or graduate or professional schooling. I'm a little bit of a poster child for, I'm literally wearing a U of T sweater. Like I love it so much. It's given me so many great opportunities being directly connected to the hospital district on University Avenue. So in terms of the human bio program specifically, I saw somebody put a comment that absolutely fantastic because it's so broad and you kind of get to build your own degree. So the first 2 years of your undergraduate degree are going to be very general. They're the worst 2 years of your life. And then I promise after that, it becomes really fun because you get to decide what kind of electives you want to do. And the only other thing I would say is number one, being open to different things and don't stress yourself out. You don't have to take the hardest courses. No one's telling you to take the advanced calculus and not the general calculus, because in the long run, it really doesn't make a difference. Really schedule time for self-care throughout the whole university process. Don't be afraid to reach out and talk to people, whether it's friends, therapists, family members. Having a supportive community around you is really what's going to make or break your university experience. I was really fortunate to have a really big friend group and meet a lot of people in my undergrad. And if anything, be going to U of T because it's so big. If things don't work out, there's endless opportunities because you're going to be meeting so many different people so fast. Yeah. Sorry, does that answer some of the
I think that
inquiries?
was a good piece of advice and answered a
Okay.
lot of what was
Yeah.
asked.
Yeah, don't worry about the first 2 years. Honestly, nobody likes them. It gets better after that.
Growing pains, yeah.
I,
And
I'm I don't know. I'm just gonna put this out there. I almost failed my first 2 years. So like I was very much on that sliver of not passing. And then it got better.
you made it here, so that's pretty impressive.
That's what
Yeah.
I say. It's to do a master's degree, only your third and fourth year matter. It's good.
So I see a question here for Inez. Does not speaking the same language as a patient affect how you're able to help them with their speech, and how do you overcome this barrier? I think you mentioned Duolingo. Also, would difficulty in swallowing be a result of the epiglottis's inability to cover the larynx for some reason/injury? Two-part question there.
Okay, so you know what? I'll answer the epiglottis question first because that's an easy answer. Yes, actually, absolutely. Swallowing can be affected by the immobility of the epiglottis or reduced mobility of the epiglottis for it actually could think of maybe two reasons why it would be the mobility would be impacted, but that would be much too detailed of an answer. But yes, so the primary role of the epiglottis when we're swallowing is to cover the airway and divert food towards the esophagus rather than to the trachea. And so if it's not fully covering the entrance of the airway, that's how food and beverage or bacteria can get in. So yes, and the first part of the question was if not speaking the same language as a patient can impact assessment and treatment. Yes, it can. And thankfully, we do have on-call interpreters that are truly so wonderful and such an amazing resource. We can call them like just on the phone. I have their number on speed dial. And we also use iPads for video interpretation. We can also, if we plan ahead of time, we can get interpreters to come in person. So a lot of the time, actually the service coordinators on the units will book an interpreter to come in person on a patient's first day in rehab if they know that they don't speak any English. So they'll get an interpreter in their first language. Now, it can make assessment, it certainly makes assessment trickier for a number of reasons. One of them being sometimes like the questions themselves are not very like applicable if words that we're testing like we're assessing a patient's word finding ability, for example, with a few images and seeing if they can name these images. And then some of the patients there isn't a word in their language for that object, or they've just never seen that object because it's not common in the country that they come from. Like one of them was actually, yeah, what one word is canoe, right? They would just call it boat. So we have to be sensitive to that. And I have sort of like started to I know like which words don't really like translate well to other languages. And like I've picked up on like kind of like the niche differences between like the English and other languages. Or sorry, the English version of the assessment and other languages. But we still like we can overcome it with like a really good interpreter. When it comes to treatment, that can be tricky as well because and primarily because of the extra time that's taken up by interpretation. So whereas like an English speaking patient could get 45 minutes of therapy, technically a patient who doesn't speak English is getting half of that because half of the time is just the interpreter repeating exactly what I've already said. So that's actually why it's very, very helpful for me to learn on Duolingo because even if I can't confidently speak the language, I can at least understand so that when the patient gives their answer, I can tell the interpreter, you don't have to interpret for me. I understood what they said. Just I'm going to tell you what I need to say, and then you're going to make it sound a lot better than I could.
That's so amazing that you are still choosing to go and learn the language as well. But that was very cool. I didn't think about canoe and things like that. And we are running out of time, so I'm going to just quickly ask. I think I saw a pre-submitted question from the registration form that maybe is specifically for Hanan. They were asking about how you're kind of designing devices for people with disabilities, which is very broad depending on what the disability is. But maybe do you want to briefly answer kind of how that factors into your work? Are you looking at a specific disability or population in that sense?
Currently, a lot of our research is focused on people who use mobility devices. So we are doing that study to see how the built environment can be made more accessible to them. But we also did research about wayfinding technology. So that's just anything that helps you get around. So Google Maps could be a wayfinding technology, kind of an area we're focusing on right now.
That's very cool. And I think you mentioned earlier too that, sometimes when you work on one thing for accessibility, it ends up improving things for everyone, not just that specific group. So that's cool.
Yeah.
We are running out of time, so I'm going to just throw it to our panelists, all three of you, maybe in the order that you presented. If you had one piece of advice to give a high school student, very briefly in a single sentence, what would that piece of advice be? Madalena, do you want to go first?
Super easy for me. Be open. I never thought of myself as a researcher. I always thought I'd be a clinician. And sometimes you don't really know where you're going to end up. So be open.
Thank you. Hanan?
I kind of didn't plan anything I did. I would say kind of plan, maybe just research what different programs are, like what you can do with your program. I just really flew by the seat of my pants and I ended up here and that's great, but I would have suggested maybe exploring every route possible because yeah, you don't know what you're gonna do.
Okay, be open and explore options. Inez,
Yeah.
what about you?
So I mean, the route to speech language pathology, there's basically one road to get there. So the question would be whether you take it or not. I would say, you know what, much like Madalena said, be open because the first time I heard about speech pathology, I actually thought, nope, that's not for me. And it turns out that there was so much more to it than I initially thought. And actually, even when I started the program and I found out that we do, like we help with swallowing, I thought, oh my God, I don't care about swallowing. I've never cared about swallowing. And now I'm such a swallowing nerd. I'm so obsessed with it. I love it. So definitely be open, research, all the different ways that speech pathologists like work with people. And if there is even one of those ways that interests you, it might be worth it. But another piece of advice is, um, be prepared for the work and be aware that it is a burnout profession. So I'll leave you with that and then you can do your own research.
Thank you. And Madalena, your hand is raised. Did you want to add?
Yes, I just want to say one thing because I was one of these students. Being a medical doctor is not the make or break of your entire life. I promise you. I'm sure everyone in this panel, like more than 50% of us, either want to be a medical doctor, think we're going to be a medical doctor. There are so many rewarding careers in medicine and helping people and making the world a better place. So please don't like be your own worst critic. Being a medical doctor is great, but there is so much more to explore.
Thank you. And I think that is a nice kind of wrap to our final STEM talks for the year. So I'm just going to get my screen shared again. There we go. Well, thank you everyone for attending today's event, and special thank you to our panelists for sharing their advice and all their kind of experiences with everyone today. If this is your first time attending our STEM Talks event, unfortunately, this is the last one for the year, but we do record all of them and post the link to our website. So if you want to explore those other careers that Madalena mentioned, you can even go to our website and look at those other panels.